Welcome to Community Health Matters. I'm your host, Amy Marsalis. On today's show, we'll learn about heart disease in women, the growing problem of antibiotic resistance, and autism resources and research. All of that coming up next on Community Health Matters. From the News Channel 5 network, this is Community Health Matters, sponsored by the United Health Foundation. Hello, everybody. I'm Amy Marsalis. Good to have you with us. Dr. Melissa Walton-Shirley is my first guest today to talk about heart health, particularly in women, because despite so much conversation about breast cancer, which is a huge focus and should be of our attention as women, heart health is actually, heart disease is our #1 killer. Isn't that right?
Absolutely. And you're correct. We need to focus on breast cancer awareness. But people don't really understand the scope of heart disease in women. 1 in 31 women will die of breast cancer. 1 in 3 women will die of heart disease. And that does not even take into account the prevalence of heart disease in 1 in 4 women.
Why is it that women are not paying as much attention? You know, the campaign Go Red for Women has been around quite a long time. I was involved with that several years back and did a lot of medical reporting. Are women getting the message?
They're getting the message, but the problem is that we're in denial. And we are the consummate multitaskers. So we're taking care of our parents, our children, our spouses, but we're not doing a very good job of taking care of ourselves. Furthermore, women don't enroll in studies like we should because we're just so busy. We're focused on picking up the children, picking up the laundry, taking care of the household and our jobs, and we just don't seem to enroll or take the time to take care of ourselves and examine ourselves or listen to our symptomatology.
And symptomatology, speaking of that, what are the symptoms for women? Because I remember, if things haven't changed, those symptoms could be a lot different for women and present themselves differently than in men. You may not have the crushing chest pain.
Absolutely. We do occasionally have typical presentation, and that's easy for your practitioner. If you come to the emergency room or your physician's office, grabbing your chest, saying you're having chest tightness, chest pain radiating into the jaws or the arms, that's fairly classic. But unfortunately, many women present with a prodrome of just extreme fatigue, and the fatigue is often an indicator of an inflammatory problem, maybe a subclinical infection of some sorts. And then we often have upper back discomfort and shortness of breath upon exertion. The problem is that we don't just have a heart attack from fixed obstruction within the artery or a blockage in the artery. We also are subject to coronary vasospasm, meaning that the artery just suddenly spasms, creates a stagnant flow state, and then clotting, and then we get muscle death, which is the definition of a heart attack. So we have to be ready. Typically, any symptom from the belly button to the level of the earlobe, front or back, that results in an impending doom type feeling, shortness of air, chest pressure, those are more typical for the atypical presentation of women.
What would cause the spasm?
Well, we think there are a lot of things. For instance, the lack of estrogen may make us more prone to spasm in some situations and then less prone to spasm in others. Adrenaline surge, for instance, particularly stressful situations like a death in the family, a chronic illness in a family, difficulty with interpersonal relationships, those things make us very prone, but also smoking. The #1 cause of coronary vasospastic angina in the younger population. And I have treated several patients in their late teens, mid to late 20s, early 30s that have had coronary vasospasm. They have a heart attack pattern on their EKG, or they have enzyme leak on their lab work, but when we take them to the cath lab, they don't have fixed obstructive disease, yet they've suffered a heart attack. So it's really important to try to figure out what type of heart attack your patient suffered from.
what are some of the other risk factors? We know smoking, but your genetic predisposition is a big factor. How big of a factor is it?
Oh, absolutely. It's one of the biggest factors. You know, smoking can move your genetic predisposition earlier. We've seen in twin studies now that there are genes that are actually turned on by tar. And twin studies have demonstrated that the non-smoking twin is free of coronary disease. The smoking twins already had an angioplasty and maybe a bypass surgery. So smoking is a biggie for risk factor. But there are also the traditional risk factors of hypertension, high cholesterol, particularly elevated LDL. Unfortunately, diabetes is rampant in our population. And if you calculate your body mass index and it's in the 30s, and you do that by Googling your body mass index, scoring your height across your weight, if you're up in the 30s, then most people are glucose intolerant, which is a very nice way of saying that you're diabetic. It creates an inflammatory condition and increases our risk of heart attack. Then there are kind of the non-traditional risk factors of rheumatoid arthritis, psoriasis. Those things are inflammatory conditions.
I've got two more quick things before we wrap up. LDL, that's the bad cholesterol,
That's right, yes.
And that's the one, HDL you want to be high.
That's right.
High density.
That's right.
And you can raise that with exercise, right?
Yes, absolutely.
Okay, but one thing that we've got to touch on before we wrap up is the test. You said that if you don't do anything else, get this test. Let's talk about the CT test you mentioned.
Yes, CT coronary calcium scoring. It's been a game changer for me as a cardiologist. So for a patient in their 50s who have significant risk factor profile, we as adults should never have any coronary artery calcium. So we're born at a level of 0. And if we can make it through our entire lifetime with a calcium score of less than 100, then our risk of heart attack is much lower than patients who, say, walk in with a calcium score of 5,000 or 10,000. And it's really, really easy to do that test. As a matter of fact, we talked about breast cancer in women and how we're very willing to do a mammogram, but we don't like the thought of the hassle of a stress test. You just walk into the CT scanner, no IV, no contrast. You don't even have to get undressed unless you have wire in your bra. You get on the CAT scan table, hold your breath 10 seconds, we photograph your blood vessels, and there's a package on the CT scanner that calculates the calcium score.
How do you get the test? I mean, how do you set it up, arrange it?
Unfortunately, Medicare and third-party payers don't pay for it, but fortunately, it's very affordable. It's the best $69 to $100 that a person will ever spend as an adult, and preferably in patients over the age of 50, unless they have a really dense family history of heart disease at an earlier age. So you can learn a lot from it. It's very difficult to have a heart attack with a calcium score of 0.
Okay, one last quick piece of advice in the next 15 seconds before you go. Most important thing women can do to take care of themselves.
Mediterranean diet, Google that, walk 30 minutes 5 days per week, have your blood pressure checked, beg your heart specialist or your family doctor to do a 2-hour glucose challenge. Don't smoke. That's my best set of advice right there.
All right, boy, you're good. You've done this before.
A few times.
All right, and love the outfit.
Thank
you for coming in
Go
and
red
sharing.
For women.
Yes, go red, ladies, go red. All right, and men, support your women and make sure they get their hearts checked. Dr. Melissa Walton-Shirley, thanks so much.
Oh, thanks for having me. We appreciate it.
Okay, thank you. We'll be right back.